Elizabeth Mueller. I am the Division and Fellowship Director of Female Pelvic Medicine and Reconstructive Surgery at Loyola University Chicago Stritch School of Medicine, and I have the great fortune of being trained in urology, but then doing a fellowship in female pelvic medicine, but trained by a urogynecologist. So I've had the opportunity to kind of live in both worlds and have the advantages that I see in both worlds in taking care of women and their pelvic floor problems. I do think there are great applications for 3D transvaginal ultrasound in the pelvic floor. I just don't think that they're focused on detecting prolapse, which we've been able to detect from the beginning of time. I think what they are very good at is some very unique applications. For example, I bet I use it weekly to try to answer a specific question I might have about mesh. It's the only modality that I know that can see mesh. I have a lot of women who come in, they've seen the recent television commercials about mesh. They're very worried because maybe they had a mesh placed, they're still having some symptoms, they're having painful intercourse, or they're having pain when they stand. They've been to a physician, they come with an operative report that says not only had they had the surgery, but somebody went back and removed the mesh, or they removed a portion of the mesh. I can even have the pathology report in front of me, but then when I examine the woman, I can still feel a very strong band anteriorly or somewhere in the vagina, and I'm trying to understand myself, is that scar tissue or is that residual mesh? Do you know that I don't have a single modality that can answer that question? CT cannot do it, MRI cannot do it. We used to even talk to the mesh manufacturers before we understood that ultrasound could see mesh, and started asking them if they would start to weave in a piece of metal into the mesh that would allow us to see it on MRI. And imagine, honestly, imagine my personal surprise when we first got the BK ultrasound. We were using it to look at the levator floor, and I started using it. We had a group of women that we were involved in a study, and I started being able to see mesh. I couldn't believe it. I could see the weave of the mesh, and then we started being able to easily differentiate whether someone had a TVT or a TOT. We could start looking at asymmetry of mesh, and even at times, although usually I would use a cystoscope to look in the bladder, I've had like one unique case where there was mesh right in the midline of the bladder. It was a sling that had been misplaced, I believe. And I could not understand how to approach it because the mesh was right in the middle. I like to not start with the arm that's right in the bladder, and I was trying to find out where's the other arm so I knew where to make the vaginal incision. Bam, I just did the ultrasound, I could see it in 3D, and that helped me decide like that I would go in on the left side, because truly the mesh that was supposed to be the right arm of the mesh was what was going through the bladder. So those kinds of things. How are you going to approach the problem? Is there a problem? How much mesh is in? How far back do I have to go? I've taken measurements and then gone ahead and used those exact measurements during surgery to say, okay, that was back about 3 centimeters from the urethral orifice, and I'll make a little incision, I'll make a little mark there, and then that's where I'll start my incision and wait till I find that leading edge of the mesh. And then I also know that I need to get out about 4 centimeters, and so I know how far to travel. Sometimes with your scissors, you'll come through the mesh. Imagine just a soft plastic screen. So if you're operating and you're pushing, you can just tear that mesh. That's not that difficult. And so now, if I did, then I would leave a band of mesh left. I would think this is the end. It doesn't have a little sign that says the end, you know, so you really have to, and yet if I lay that out and I know that on that ultrasound image I had about 4 centimeters, and I look at this and this is 2.5, I know, you know what, I've got some more in there and I need to continue that dissection. You just can't ask for anything better.